If you're an anesthesia student, you know that ECG line on the monitor is way more than just a squiggly line. It's the real-time story of your patient's heart, and that story can change in a heartbeat, literally. So today, we're going to break down the most critical ECG rhythms, pulling some amazing insights straight from Dr. Farhad's notes. Let's jump right in.
Okay, so this is where it all starts. On the left, you've got the heart's electrical wiring, kicking off from that SA node. When that signal travels perfectly down the line, you get what you see on the right, that beautiful, predictable, normal sinus rhythm. See that? Every P wave, that's the atria squeezing, is followed perfectly by a QRS complex, which is the ventricles. Think of this as your North Star. It's the baseline we compare everything else to.
So here's our game plan. First, we'll nail down the anatomy of a normal heartbeat. Then, we'll hit the big ones, the arrest rhythms. After that, we'll see what happens when the heart races, and then when it drags. And we'll wrap it all up with a clinical framework to put it all together.
All right, Section 1, Anatomy of a Heartbeat. You absolutely have to master what's normal before you can even hope to spot what's wrong. Every little deviation from that perfect sinus rhythm we just saw is a clue, telling you exactly what's going on with your patient.
Okay, now for the rhythms where every single second counts. These are the arrest rhythms. You have to recognize these patterns instantly because, no exaggeration, a life absolutely depends on it.
And this is what electrical anarchy looks like on a screen. It's ventricular fibrillation, or VFib. There is zero organization here. No P waves, no QRS complexes, nothing. It's just a chaotic, quivering mess. You hear people say it looks like a bag of worms, and that's exactly what the ventricles are doing. And a quivering heart is not a pumping heart. So why is this so bad? Well, in VFib, the ventricles are just getting zapped by chaotic impulses from all over the place. There's no coordinated squeeze, just a totally useless quiver. And, well, without that squeeze, there's no blood flow to the brain, and the patient goes down. Simple as that.
So you see this. What do? What's the plan? Job number 1, shock them. Early defibrillation is the only thing that's going to reboot this chaos. While someone's getting the defibrillator, you're on the chest, starting high-quality CPR and getting oxygen on board. After the shock, you bring in the drugs. Epinephrine to boost blood pressure, and antiarrhythmics like amiodarone to try and stabilize things and keep it from happening again.
All right, so we've covered a heart that's basically not beating. Now let's flip the script and talk about one that's beating way too fast. Let's dive into the tachycardias.
Okay, this is absolutely critical. Before you even try to figure out what the rhythm is, you got to look at your patient. Are they stable or unstable? Are they awake? What's their blood pressure? An unstable patient with a tachycardia needs electricity, and they need it now. A stable patient? Well, that buys you some time to really diagnose the rhythm and pick the right drug. This is always your first step.
Okay, let's kick things off with two of the most common ones you'll see. Atrial fibrillation is just pure chaos. It's famous for being irregularly irregular. There's no pattern to it at all. Atrial flutter, on the other hand, is a little more organized. Its signature look is that classic sawtooth pattern. Let's see them side by side. And yeah, looking at them like this, the difference is just crystal clear, isn't it? On the left, you've got AFib. The distance between those R waves is completely random. It's just chaotic. Now look to the right at A flutter. See that textbook sawtooth pattern? Much more regular and predictable.
And this is a real gem from Dr. Farhad's notes, a golden rule really. If the rhythm is irregularly irregular, it's AFib, period. It's one of the very few things that's basically an absolute in ECG interpretation. So you want to lock this one away for good.
All right, let's move a little further down the heart's wiring to a rhythm that starts in the ventricles. This is monomorphic ventricular tachycardia, or VTAC. The two things to look for are a wide QRS complex and the fact that they all look exactly the same. That's the monomorphic part, right? Mono meaning one, morphic meaning shape. One shape.
So what is VTAC really? Technically, it's just 3 or more of those premature ventricular contractions, PVCs, in a row. A stable patient might not even feel it. But this fast, inefficient rhythm often causes symptoms like dizziness or low blood pressure. If they're stable, you've got time for meds like amiodarone. But the very second they become unstable, you cardiovert, no question.
But hey, not all VTAC is created equal. This is torsadas de points, which literally means twisting of the points. And you can immediately see why. The QRS complexes look like they're twisting around an invisible line, getting bigger, then smaller, in this beautiful but incredibly deadly dance.
You see that twisting pattern? And it should be a giant red flag. It's telling you the root problem is a long QT interval. And that means the treatment is different. So this is key.
don't just reflexively reach for amiodarone. The first-line treatment for torsades is magnesium. It helps stabilize everything.
All right, we've dealt with the speedsters. Now let's hit the brakes and talk about what happens when things get too slow. Welcome to the world of bradycardias and heart blocks. The problem here isn't speed, it's a lack of it.
And just like with tachycardias, the very first question is about the patient. Are they symptomatic from this slow rate? If they are, here's your step-by-step game plan. First, you can try atropine, which basically blocks the nerve that's slowing the heart down. If that doesn't cut it, it's time for electricity. You put the pacer pads on. And if you still need to get that blood pressure up, you can start an infusion of dopamine or epinephrine.
Okay, let's dive into the heart blocks. This right here is a second-degree AV block, type 1, but pretty much everyone just calls it Wenckebach. And trust me, once you learn the pattern, you'll never, ever forget it.
This right here nails it. Just keep your eye on that PR interval, the space between the P and the QRS. In Wenckebach, it gets longer, then a little longer, then even longer, until poof, a beat gets dropped entirely. The classic saying is longer, 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 drop. That's Wenckebach.
All right, now for the big one, the most dangerous of the heart blocks, third degree or complete AV block. This is a total breakdown in communication. The atria and the ventricles, they are not talking to each other at all. Think of it this way. The P waves are just marching along at their own normal rate, doing their thing. And the QRS complexes, they're also marching along regularly, but to a completely different, much slower drummer, because the ventricles are using their own backup pacer. But look closely, there is absolutely no relationship between them. This is a true emergency, and this patient needs a pacemaker stat.
Phew. Okay, so we've looked at the chaos, we've looked at the fast, we've looked at the slow. Now let's tie it all together with a simple, practical, clinical framework courtesy of Dr. Farhad that you can pull out in any situation.
So here it is. The next time you walk into a room and see a fast heart rate on the monitor, this is your mental checklist. 1. Are they unstable? That is always priority number 1. 2. What's their cardiac function like? This is going to guide your choice of drugs. 3. Could this be WPW syndrome? You got to rule that out because some drugs are a no-go. And 4. How long has this been happening? This is so crucial for thinking about clot risk, especially in AFib. Master these 4 questions and you'll be ready for any tachycardia that comes your way. So what are some of your favorite clinical shortcuts?